Greetings. My name is Natalie Banet. I am an assistant professor of pathology and laboratory medicine at Women and Infants Hospital in Providence, Rhode Island, and I'm working on recording lectures for distance learning in the setting of the COVID-19 outbreak and everyone social isolating, which I think has affected a lot of trainees in the medical profession. So just trying to get all this down to try to help those who are still in the process of learning in a very interesting and difficult time. So this is one of my first attempts, so I'm going to record this lecture that I gave at a departmental meeting maybe 6 months ago, though time is a continuous circle and I honestly don't remember. But it's a case which I turned into a differential diagnosis presentation on spindle-celled lesions of the uterus with myxoid morphology. And just as a brief background, my training is in GYN and cytopathology. So GYN pathology is a great love of mine, and I hope you find this helpful. If you need anything or have any feedback for me, my email address is nataliebanet@gmail.com, and then I'm also on Twitter at nataliebanet. So let's get started. Computer didn't like that. All right, let's try this. That worked. Okay. Clinical presentation as a 51-year-old female who presented for a hysterectomy for a large uterine myometrial mass. There was no significant medical history. The uterus was sent, or the specimen I say was sent for frozen section due to concern of the surgeon due to the size of the mass. This was actually my frozen section, and the specimen was fragmented during removal in a laparoscopic bag, which is not uncommon, especially with specimens taken out through the vagina. Go back to that. So the first image here is a low power image of the frozen section, which you can see has a lot of artifact, but there is some indication, at least to me, with the spacing of the cells, that there was something in between those cells. Things that can cause this kind of change are a lot of water in the tissue, so hydropic change or swelling. Also things like mucin, which is sort of hinted at given those purple strings which are running across the plane of section. So that, at the time at least, was something I was thinking of. And grossly, I do remember this lesion did look myxoid. Yeah, okay. The next image is another image of the frozen section, which shows a higher power in an area where it has more conventional areas suggestive of a spindled lesion with elongated nuclei. The cytoplasm here looks a little more eosinophilic to amphiphilic, but then you do see it sort of merging with those areas which are more characteristic of the former slide, with more swelling and space between the cells. I would say that the nuclear pleomorphism here is a little bit greater, although I always interpret that with caution on frozen sections because the artifact of freezing the tissue is so marked. And so, at least in my training and the way that I approach spindle cell lesions on frozen is I don't usually, almost never do I give a definitive diagnosis on a spindled cell lesion because the criteria for leiomyosarcoma and things like that are so stringent that it's really hard to do that on a frozen section. So I usually say something to the effect of what I said here. Spindle cell neoplasm cannot exclude malignancy, or if I'm really not worried about it, I'll say spindled cell neoplasm with no mitotic activity, necrosis, or marked atypia, defer to permanent section. But here I was a little more concerned, especially given the myxoid change. So I said spindle cell neoplasm with myxoid differentiation cannot exclude malignancy on frozen section, and the surgeon stopped with hysterectomy and left the patient's tubes and ovaries. I don't think the patient was expecting anything other than maybe like a leiomyoma diagnosis, so that's why the surgeon decided to manage the patient that way. On permanent section, some of the areas of the mass showed what I would consider pretty banal histology, with sort of alternating areas between more loose and more dense or cellular areas. On higher power, you can see that the cytomorphology of those spindled cells is pretty benign looking. The nuclei are small. I don't see necrosis here. I don't see mitotic activity. I don't see what I would consider significant nuclear atypia. This is another area, though, where you can start to see that some of those areas in the more cellular at the top of the screen and the less cellular, it does appear that there is actual mucin between the cells, which is interesting. And once you get into that differential diagnosis with spindle cell lesions, you're in a little bit of a different category. And this is another high power view of the areas showing mucinous differentiation. However, the histology, the cytomorphology is pretty benign. Here we start to get into areas that are a little more cellular. This is a little more concerning to me. There is some nuclear atypia in here, which makes me sit up and pay attention, especially since it's a myxoid lesion. Your thresholds can be a little bit lower. We're going to get into the diagnostic criteria here in just a minute. And then I started seeing mitotic figures. So these don't photograph extremely well, but I will promise you that that's an actual mitotic figure. And then in other areas, you start to see two, and maybe even that one in between is another mitotic figure. So up to, actually, there's one at the top left-hand corner too, possibly. Although, like I said, these aren't photographing well. And sometimes you can get pycnotic material that looks a lot like a mitotic figure. It's really best to do with your microscope and a glass slide. And then in other areas, you see where the mass had an interface with the surrounding myometrium, which is an important thing to evaluate in smooth muscle and other spindled lesions of the uterus, is this interface between the two was not regular, and there was this sort of tongue-like pushing infiltration into the surrounding tissue with not very much cellular material, but a lot of mucin, which is also concerning. So the way my mind works, and I think this is just over years of becoming a pathologist and just sort of rote memorization, is once you arrive at a differential diagnosis, you sort of walk through each lesion in the differential diagnosis and try to convince yourself that what you're looking at is or is not that lesion. So these are the 5 things that would pop into my mind for this differential diagnosis, although there are probably others. These are the ones that I thought were probably most likely. Leiomyoma with myxoid degeneration, Myxoid Leiomyosarcoma, extravasation of mucin from an epithelial proliferation of the uterus, inflammatory myofibroblastic tumor, and then endometrial stromal sarcoma with myxoid features. So we'll start with the Myxoid Leiomyosarcoma. This is compared with conventional leiomyosarcoma, more aggressive and carries a poorer prognosis. It is extremely rare, only having been described about 100 times in the literature, and like conventional leiomyosarcoma, it's more common in postmenopausal women. The criteria that we think of for leiomyosarcoma, any aficionado of gynecologic pathology runs through these in your head. Like I said before, nuclear atypia, tumor or coagulative like necrosis, and mitotic activity. Those are not the same for myxoid leiomyosarcoma. Oh, sorry. Just cancel that phone call. Okay. You must evaluate the border for these lesions with surrounding myometrium, like I mentioned before. And then mitotic activity may appear low because of hypocellular areas, but most authors agree that even if you only have 2 mitotic figures per 10 high-power fields, it's enough to call malignant with the other features present. So significant nuclear atypia is not necessary, and necrosis is not necessary in this context. So here is a review or an article where the authors, it's a really great paper where they took 30 cases of uterine myxoid mesenchymal neoplasms and sort of reevaluated them given what we know now, and went through and described the features. So they came up with this very helpful table, which I think, like I said, as a pathologist, I think over time this is just sort of how my mind works. I don't know if this is true for every pathologist, but you sort of run through a checklist in your head. So you start with tumor border. Is it irregular? Is it smooth? Then you go down to nuclear atypia. Is it there? Is it hardly there? And then do you think it's mild, or do you think it's moderate to severe? So you sort of have a nice break point for yourself. I sort of think of moderate to severe as significant and then non-significant. And then you count mitotic figures. And what they found was myxoid leiomyosarcoma, if you follow this algorithm, you can sort of lump the myxoid leiomyomas and then separate out stumps, or the sort of intermediate category from myxoid leiomyosarcomas. So this is their big table where they basically took all 30 cases, and what they ended up finding was there were 4 cases which they took out of the pool of leiomyosarcoma-like patterns. Some of them ended up being inflammatory myofibroblastic tumor. I have a picture of that later when we talk about IMTs. But of all the cases that were myxoid leiomyosarcoma-like, the mean size was about 11 centimeters. They had almost all had an infiltrative border. They were almost all hypercellular. They almost all had some nuclear enlargement. Only a small percentage had marked nuclear enlargement, which is what, like, they're saying that the atypia doesn't have to be severe. Hyperchromasia was present in almost all in all cases. And then the psi, or the mitotic activity, was actually pretty high. The mean was 12.9. The median was 14. And then atypical mitoses were not common. Necrosis was present in about half the cases, and then LVI was present in about 40% of the cases. So that's just interesting to keep in mind, because we sort of tend to sort all leiomyosarcomas into the same bucket when really these are morphologically different. And we went over all those out. And then the other thing I'll mention is that IHC in these cases, CD10 was positive in a lot of cases, which you have to think about when we talk later about endometrial stromal sarcoma. And then smooth muscle markers, especially Desmond, was positive. And then in 3 of the cases, ALK was positive, and in 2 of 3 of those cases, it was negative by FISH, but 1 case, I don't think they really sorted out. This is a figure from the paper showing a macroscopic appearance of myxoid leiomyosarcoma. You can see it is sort of yellow and gelatinous, especially as compared to, in figure B, you can see a conventional leiomyoma at the bottom right-hand corner of that picture. And then you can see the infiltrative interface with the tumor and the myometrium. This is their other figure, which shows the infiltrative border in the top left corner. And then in part B, you can see mitotic activity and nuclear atypia. And then they actually did an Alcium blue stain, which highlights the myxoid extracellular matrix. Figure D is Desmond, E is Cal-Desmond, and F is ALK, which was negative in this case. So the second differential we'll talk about is a leiomyoma with myxoid degeneration. So leiomyomas with myxoid degeneration should be circumscribed, and the myxoid appearing areas are hydropic change actually associated with degeneration. And I would say pound for pound, if you're just talking about cases that you'll encounter more commonly, you'll definitely see this more commonly, especially in my experience in sort of like younger patients and perimenopausal patients who have large leiomyomas. Usually there are other degenerative changes present, like hyalinization or infarct or hyaline type necrosis, and this will sometimes be at the interface of where that's happening, and then there's a more conventional part of the leiomyoma in my experience. The mitotic activity should be low, nuclear pleomorphism shouldn't be significant, and then adequate sampling is paramount, especially at the interface with the myometrium, to prove or disprove this area, this circumscription idea. And then another thing I find helpful, because I send myself back to the bucket on these frequently, is when I'm looking at them grossly, or looking at them with the PA, is to find an area of necrosis and sample or softening, because sometimes that's what these end up looking like, softened, is to find an area where the softened area meets a more firm area, just to get a better idea of what that interface looks like microscopically. So this is an image that I took myself of myxoid degenerated leiomyoma, and you can see there's space between the cells, but it's not mucin. There's not that blue tinged material that we saw in the prior case. And also the cells in the background cytologically look very innocuous. I don't see any mitotic activity. I don't see any significant nuclear atypia. And then here's just a higher power view of the same case where you can see those spindled cells, no mitotic activity, no significant nuclear atypia. And on a higher power, the same thing. So a good idea of that. And then even higher power view of that nice sort of hydropic change between the cells. The third entity we'll talk about is an inflammatory myofibroblastic tumor, which is a myofibroblastic neoplasm of intermediate malignant potential, which frequently shows fusion of ALK with other genes and is the in the gynecologic tract, the most frequent site for these neoplasms is the uterus. You should have an interspersed inflammatory infiltrate, which we'll talk about in a little bit, especially plasma cells and lymphocytes. And then these can have an intermediate clinical course, but can be locally aggressive. So it's important to recognize them, especially to differentiate them from a thing like a thing which would have no potential to do that, like a benign leiomyoma. Grossly, these are usually myometrial masses. They can have a mucoid gross appearance. The myofibroblasts are spindled or stellate shaped. They have granular nuclei and can have nucleoli with pale eosinophilic cytoplasm, usually relatively low mitotic activity with rare atypical mitotic figures. And then the edematous background should have inflammatory cells like we talked about before, and these will actually be positive for Desmond and SMA, but also positive for ALK. So this is a low power version. The resolution isn't so great, but you can get an idea that there's also that spacing out of the cells, that hydropic looking change. And on a higher power, you can see the nuclear atypia, I would say, is mild to moderate. The mitotic activity, I'm not seeing a lot of mitotic activity here, but I do get an inclination that there might be inflammatory cells, which we can see at a higher power. There are some lymphocytes here as well as some plasma cells, and that's not coming through great on this image, but I can tell you under the scope it was a lot easier to see. And you can see here some inflammatory cells as well. And here you're getting an idea of some pycnotic change, but also some inflammatory cells. This is the other figure from the paper we talked about myxoid leiomyosarcomas, where they found those 3 cases where they went back and looked at all of them, where they ended up actually classifying them as IMTs. And you can see in figure A, spindled cells with myxoid stroma, and at higher power admixed with, in part B, inflammatory cells. In part C, the Alcium blue once again stains the mucin, the mucoid matrix, and then in part D, Desmond, in part E, ALK is positive, and then in part F, that's a dual color break apart fish for ALK, which proved the rearrangement. This is a separate paper about ALK being a specific diagnostic marker for inflammatory myofibroblastic tumor of the uterus. And in summary, 14 cases of inflammatory myofibroblastic tumor of the uterus were found with molecular confirmation, and then 260 other mesenchymal and mixed tumors of the uterus. All of the cases of IMT were positive for ALK, and none of the other cases were. So their argument basically is that if you use ALK, it's very helpful in differentiating these neoplasms from, say, a smooth muscle neoplasm. This is a figure from that paper, which shows that cases can be more cellular and certainly can mimic a smooth muscle tumor, but that the ALK immunostaining shows granular cytoplasmic staining with perinuclear accentuation. The fourth entity we'll talk about is endometrial stromal sarcoma with myxoid features. Various endometrial stromal sarcomas can show myxoid differentiation. I'm not going to focus on every single kind, especially since the classification of ESS is the topic of an entire different lecture. It's become so interesting in the past couple of years as various molecular techniques have allowed us to refine that. But there is a recent description of a high-grade endometrial stromal sarcoma with this fusion, this ZC3H7B B-core fusion, which shows myxoid features. These tumors have limited follow-up, but there is a suggestion that they present at a higher stage and have a worse prognosis than low-grade endometrial stromal sarcoma. So here's a paper with 17 cases of this newly defined entity from 2018. And the tumor involved the endomyometrium in most cases. There was uniform cellularity, punctate nucleoli, and ovoid to spindled cells, and it resembled, the resemblance to endometrial stroma like in a low-grade ESSS was not seen. However, it did have tongue-like infiltration pattern, similar to that noted in low-grade ESS, but many cases also had a pushing or only had a pushing border of infiltration. Areas of typical or low-grade ESS were not seen. There was necrosis in a majority of cases, mostly infarct type, and LVI was present in a majority of cases. Myxoid stroma was seen in 14 of the 17 cases, and collagen plaques in 8 of 17. Mitotic activity was widely variable, and immunohistochemical staining was positive for CD10 in all cases, cyclin D1 in 7 of 8 cases, and B-core immunohistochemistry in 11 of 14 cases, and ALK was only done on 3 cases but was negative. This is a figure from their paper showing the features of this endometrial stromal sarcoma with yellow, tan, white fungating mass which occupied the entire endometrial cavity. I think you can get a hint that we're in the whole endometrial cavity, although it's hard to tell. I think that might be a fallopian tube poking up in the sort of back right to the middle, and maybe one down in the lower corner as well. It's kind of hard to tell, but certainly this is a cut open uterus. This is a figure from their paper showing histologic features of the ZC3H7B B-core endometrial stromal sarcoma with tongue-like infiltrative growth patterns and lymph-vascular invasion noted. And it's had a broad irregular border on part A, haphazard vesicular architecture in part C, and in part B, A shows the irregular border and B shows the smooth pushing border, and then in part D, some myxoid stroma. This is another figure from their paper which shows collagen plaques, which were ball-like proliferations of spindled cells. That can be a helpful diagnostic clue, although I would argue that sometimes plain old leiomyomas show areas that look a lot like that, but if you start to see something with myxoid stroma and these, start to think about this entity, certainly. And then the fifth entity, which I think is actually pretty unlikely, and I have never directly observed it, but it was described, so I wanted to just put it in here to keep it in everyone's mind, was extravasation of mucin from epithelial proliferations of the uterus. Mostly this would be a pitfall in biopsy material. It's described in benign and malignant cases ranging from adenomyoma to carcinosarcoma, but limited descriptions are available. This is a paper which described basically the rare times when this has been noted, and it was in biopsy material, which just keep that in mind, especially on uterine biopsies. So back to our frozen section case, histologically, the case was shown, like we showed earlier, to have a fascicular growth pattern, focally at least, consistent with smooth muscle differentiation. Greater than 80% of the tumor showed myxoid degeneration, and there was destructive infiltration of surrounding myometrium. Lymph-vascular space invasion, or LVI, was noted. Mitotic activity was present up to 4 per 10 mitotic figures in a 4 per 10 high-powered fields. Immunohistochemistry was performed. Desmin and SMA were positive. CD10, ALK1 were negative. Cyclin D1 was negative, and then ER was focally positive. No molecular testing was performed. The final diagnosis was Myxoid Leiomyosarcoma. The patient did return to the operating room to have her ovaries removed. That was not something that she had desired at the initial surgery, and was placed on chemotherapy. So that is my presentation. The conclusions is that there's a complex differential diagnosis with significant morphologic overlap for spindled cell lesions of the uterus with myxoid morphology. It's made easier with the immunohistochemical techniques and molecular testing. And the gross description, as well as rigorous sampling of the myometrium and endometrial interface, is vital in these cases. And I would say for all pathologists, sending yourself back to the bucket there's no shame in that. And as someone who worked on the other side as a fellow of receiving consultations, it always made things go a lot faster when cases came in, and the consultant pathologist had already done extra sampling just to make sure that we weren't missing a focal area where things looked different, and to make sure that that's being done on problematic cases, not on all cases, but on cases where the differential diagnosis is giving everyone some trouble. So I hope you found this helpful, and I appreciate any feedback you have. Like I said, my email address is nataliebanet@gmail.com, and thank you so much.